Welcome to today's session in Quality Assurance in the Healthcare. In today's session, we'll delve into the critical role of quality assurance in shaping safe, effective, and patient-centered care. Healthcare systems worldwide face growing expectations for high-quality care. Since the 2000 Institute of Medical report, "To Err is Human," public and professional focus on medical errors and patient safety has intensified. Key findings: up to 98,000 deaths per year in the US could be linked to preventable medical errors. In the emergency department, while only 3% of hospital adverse events occur there, a staggering 70% are considered negligent. To tackle this, leaders must prioritize quality assurance, or QA, as a core function. As patient expectations for quality care continue to rise, healthcare organizations must respond with robust systems for monitoring and improving performance. Quality can mean different things to different stakeholders, patients, providers, and payers. Over time, the definition has evolved. The Institute of Medicine outlines 6 dimensions of quality: avoiding harm to patients from care intended to help them, providing services based on scientific knowledge to those who would benefit, providing care that is respectful of and responsive to individual preferences, reducing waits and harmful delays for both recipients and providers, avoiding waste of equipment, supplies, ideas, and energy, providing care that does not vary in quality based on personal characteristics. Our healthcare adds 3 simplified categories: clinical quality, service quality, cost efficiency. Together, these form a comprehensive view of departmental performance. QA focuses on monitoring care to ensure standards are met and identifying areas for improvement. QI actively works to improve systems, reduce errors, and enhance outcomes. They are distinct but deeply interconnected. While distinct, their approaches QA and QI work in tandem to create a comprehensive quality management system. QA identifies where standards aren't being met, while QI drives the organization towards excellence beyond baseline expectations. Together, they create a dynamic system that both maintains and elevates care quality. To improve care, staff must feel safe reporting problems, adjust culture, promote trust, learning, and accountability without fear of unfair punishment. Leaders must create an environment that reward transparency and define clear behavioral expectations. A just culture is fundamental to effective quality assurance in healthcare. It creates an environment where staff feel safe reporting errors without fear of unwarranted punishment, while still maintaining appropriate accountability for reckless behavior. Healthcare leaders must actively promote transparency by establishing clear behavioral expectations and rewarding those who identify potential safety issues. Organizations with well-established just cultures typically see higher reporting rates for near misses and system vulnerabilities, allowing for preemptive correction before patient harm occurs. Quality is tracked through licensure, which represents minimum safety standards; accreditation, where organizations undergo review by external agencies against comprehensive quality standards; pay-for-performance programs, which adjust reimbursement based on performance across designated quality domains; malpractice insurance data, using it to develop quality ratings, network inclusion decisions, and reimbursement structures. The specific requirements vary significantly by country and healthcare system, but the fundamental goal remains consistent, using data to evaluate and improve care delivery. Two influential frameworks guide quality measurement. The Dona-Biden model focuses on three key elements of quality: resources and staffing, what happens during care, and health results and satisfaction. Porter's model looks at quality through a competitive strategy lens, focuses on outcomes per dollar spent, advocates risk-adjusted outcome tracking, seeks innovation in delivery care. The Dona-Biden model provides a comprehensive framework for measuring healthcare quality across different dimensions. In contrast, Porter's model takes a different approach, focusing on outcomes achieved per dollar spent, with risk adjustment to account for patient factors. This model emphasizes the importance of tracking outcomes that matter to patients across a full cycle of care. A market basket approach gathers a balanced mix of indicators across patient acuity, condition types, process steps. Metrics must be meaningful, evidence-based, and cost-effective. Examples include wait times, return visits, acute myocardial infarction management, pneumonia care, stroke treatment. Too few metrics may miss important quality dimensions, while too many can create excessive administrative burden without proportional benefits. The best approach typically involves focused measurements of high-impact processes and outcomes. Well-designed metrics drive improvement. Poorly designed metrics, they backfire. Case example: a rule requiring antibiotics within 4 hours for pneumonia led to overdiagnosis and unnecessary treatments. Another case example: UK's 4-hour emergency department length of stay rule led to gaming, like delaying ambulance intake to manipulate the data. The lesson: choose metrics carefully with input from clinicians. Poorly designed metrics can lead to unintended consequences. To avoid these pitfalls, clinician input is vital in designing meaningful metrics. Frontline providers can identify potential unintended consequences and suggest approaches that better reflect quality care while minimizing opportunities for gaming the system. Different healthcare systems around the world have developed varied approaches to quality measurements, reflecting their organizational structure and priorities. While specific metrics differ, common themes emerge around timeliness, appropriate clinical care, patient outcomes, and satisfaction. UK NHS clinical quality indicators include time to treatment, patient satisfaction, and reattendance rates. Australia measures access block, acute myocardial infarction treatment timeliness, and care for high acuity patients. USA CMS metrics span inpatient, outpatient, and emergency department throughput performance. These international examples demonstrate how quality metrics can be tailored to specific healthcare contexts, while maintaining focus on core dimensions of quality. Peer review is central to quality assurance. It aims to determine if standard of care was met, if errors led to adverse event, if near misses occurred. The standard of care means the minimum safe care expected, not perfection and not just average. While reviewing specific cases, reviewers must consider contextual factors like resource constraints, patient volume, and available information at the time of care. This approach recognizes that healthcare delivery occurs within complex systems where multiple factors influence outcomes. An adverse event is an unexpected harm due to care, not disease progression. Types range from minor injuries to death. Severity is measured by tools like Agency for Healthcare Research and Quality Harm Scale, or AHRQ Harm Scale. An error is a mistake in execution or planning. Not all adverse events are errors, and not all errors cause harm. Root causes may be cognitive, communication-based, systemic, patient-related. Distinguishing between them provides clarity that helps identifying improvement opportunities. Adverse events without errors are unavoidable complications, while errors without adverse events are near misses that provide learning opportunities. Effective QA needs strong data, including documentation, electronic timestamps, system reports, case records. This supports both individual case review and global performance monitoring. When setting up a peer review program, two models exist. Single reviewer model, efficient but risks bias. Committee model, collaborative, reduces bias, increases input. Cases are selected by reactive methods, complaints or reports, proactive methods, high-risk cases, return visits, random audits. Structure your review asking clear questions like were there adverse events, were there errors, was care appropriate? Use rating scales to evaluate uncertainty and inter-rater reliability. Peer review balances standardization with clinical judgment, while processes ensure consistency. Complexity requires contextual evaluation. Successful programs foster psychological safety while maintaining accountability. Morbidity and mortality conferences help spread learning. They should be inclusive to capture full spectrum of care delivery and perspective. This multidisciplinary approach enriches the learning experience and identifies broader improvement opportunities. Focus on system issues, not blame, using real cases to illustrate important clinical concepts and decision points. The emphasis on education creates psychological safety while reinforcing standards of care across the team. Be educational and case-based. This approach identifies environmental factors, workflow issues, and resource constraints that contribute to outcome. Morbidity and mortality conferences, they reinforce department-wide standards of care, dating back to the early 20th century. When properly structured, they create a powerful forum for case-based learning and system improvement, while reinforcing a culture of accountability and excellence. Case study: a 65-year-old presented with septic shock. A central line placement led to pneumothorax, a known complication. The procedure followed protocol. Conclusion: this was an unpreventable adverse event, not an error. Understanding these distinctions is vital in peer review. This case illustrates the important distinction between adverse events and errors. The patient experienced an adverse event despite perfect adherence to the standard of care. This represents an unpreventable complication rather than an error in care delivery. In quality assurance, this distinction is crucial for fair evaluation and appropriate improvement efforts. Quality assurance in your department is both a science and a leadership function. It requires strong data, a just culture, thoughtful measurements, and a structured peer review. A robust quality assurance program improves care, safety, staff learning, and institutional credibility. By implementing a comprehensive quality assurance system, healthcare organizations can improve patient safety, enhance care quality, promote ongoing learning, and strengthen their credibility with patients and stakeholders. Most importantly, effective quality assurance saves lives by preventing errors and ensuring that patients receive the high-quality care they deserve. Thank you for joining me in this session. and quality assurance in the healthcare.